So this webinar will also be recorded and also will be published on YouTube for everyone. So you will be able to access it at any time. And we also will have time after the webinar for your questions. So feel free to ask them via chat. If you need the microphone, let us know and we will unmute you. So Olga will give a presentation today. So let's mute her and give her.
Hello, can you hear me?
Yes, Olga, we can hear you very well. So you can go on with your presentation and you can introduce yourself for the newcomers. So today we don't have a lot of participants. Maybe the time was chosen not very convenient. But anyway, as I told you, it will be recorded and you will be able to access and share with your colleagues and friends. So Olga, go ahead. It's your time
Okay.
now.
Thank you, Alex, and thank you everyone for coming for this lecture today. I'm very happy that I can present my ideas about anxiety disorders, and also I will try to show you some real cases at the end of the presentation. That's like usual structure of the presentation. So first some theory, and then what we can see in the real world. And let's start like generally again, what is anxiety disorder? Probably those who are working in psychotherapy or in psychological setting or in psychiatry facing with this problem quite often, but also people in generally, they can have some increased anxiety because of the normal real situation. So anxiety is not always a disease, it's also a normal emotion. And it can increase in case if you have some tension, if you have some situation at work, maybe some jealousy or some disappointment on something. Basically, when you expect something and this expectation couldn't be supported from the situation, so anxiety can increase. Another situation when you can have some increased anxiety, it's anxiety trait. And this is something to do with your personality. Some people, they simply worry more than another, and this becomes like a part of their personality of them. And of course, these people, they are in the risk to develop later anxiety disorder because they react to everything too much, let's say. They try to see the situation usually from the negative side. And this is anxiety trait. It's something what you have always with you. And anxiety state is a temporary state. It's quite normal to be anxious. It's more to do with anxiety as emotion. And this anxiety state, of course, can be very serious if you was in some serious problem, for example, in some car accident, maybe nobody hurt, but still it's unpleasant feeling, or maybe something else. So anxiety state is coming, but it will vanish eventually. It will disappear. Like anxiety trait, it can disappear. It will be always with you, and you need to learn how to deal with this. But anxiety state will come and go. Anxiety disorder, it's another, let's say, part of this discussion. And today we are mostly going to talk about anxiety disorders because they are the most prevalent in real clinical practice. And actually, therapists or doctors who working in polyclinics, they facing with this anxiety disorder clients daily, because these people, they could have different kind of symptoms like heart palpitation, elevated blood pressure, headache, and muscle tension, and many, many other things. So anxiety theories, there are many. And of course, specialists from different disciplines understand anxiety a little bit differently. And like psychologists, they talk about anxiety from the point of view that, for example, fear, it's something what we learn during our life. If something serious happened and emotions was involved, this fear conditioning or learning to be afraid of something is coming very quickly. And there's also some speculation that children, they usually don't afraid anything, but then because of the parents and their effort, they learn that they need to be afraid of certain situations. Then psychologists also discovered that people with anxiety, they have cognitive bias or errors. So they could understand some situation in a specific way. Also cognitive avoidance or intolerance of uncertainty. Psychoanalysis or psychodynamic theory talking about conflict between id and ego, so between some deep desires and some reality. And also neuropsychologists or psychologists who are working with understand and try to understand how the brain works. They're talking about emotional regulation system that involved in this psychological problem, some learning system involved in this disease, and memory system. Another approach is genetic. So it was discovered that anxiety can be inherited. So really in the families with parents who are quite anxious, we could expect that kids also can have the same type of behavior. And this is more related with anxiety trait, so part of personality of this person. Physiological theory talking about autonomic stress regulation faulty. People with anxiety, they could have sympathetic hyperactivation, parasympathetic dysregulation, hormonal regulation disbalance, like many people with anxiety disorder could present insomnia and also related disease and disease related with thyroid glands. Also some theory now coming about gut microbiome influence. Again, this is all working through the autonomic nervous system and influence our brain states and can increase anxiety. Some changes happened recently. So we had some classification for anxiety disorder, medical classification, and it was DSM-4, where in anxiety disorder we also include obsessive compulsive disorder and post-traumatic stress disorder. Nowadays in DSM-5, anxiety disorder only includes generalized anxiety disorder, panic, phobia and specific phobias, agoraphobia, social anxiety, separation anxiety disorder, and some other, but obsessive compulsive and trauma and stress related disorders, now it's different disorders, and we are not going to talk about them today. Little more about epidemiology. So anxiety disorder, it's about 26, 28, depending of who and how calculate the number of this disease. But it's quite a lot of people suffer from anxiety disorder. But we should also remember that anxiety can come as a additional symptom and coexist with other disorders. For example, here it's shown like chronic pain or depression or insomnia or epilepsy, traumatic brain injury, ADHD, Alzheimer, all of them, they can also be related with anxiety, or they can coexist. So both diseases can be presented. In population, most often we can find specific phobias, social anxiety disorder, then also panic and generalized anxiety, and female have women, they suffer from anxiety more than men generally, especially with panic disorder, with generalized anxiety disorder, and so on. And this is related with our specific hormonal changes. So additional, let's say, additional strength need in the women's stress regulation system to be able to deal with all these changes that coming every month. Okay, about comorbidity, once again, I want to tell, because this is very important to understand that anxiety, like pure anxiety, it's very hard to find. Usually it's associated with something else. Like you can see in this graph, social anxiety can coexist with panic disorder, with obsessive compulsive body dysmorphic disorder, or autism spectrum disorder could have some problem with social anxiety, schizophrenia, and anxiety is often related with major depression. Actually, depression and anxiety coexist in 1.8% cases, and they share common symptoms like sleep problem, concentration problem, fatigue, irritability, or psychomotor agitation. And you may face this situation in the real practice when a person come to you and was diagnosed with some depression, but at the same time they have anxiety. So both this disease, they coexist. Of course, pandemia bring additional problem to the society, and we have increased number in depression and especially in anxiety. And anxiety increase a lot in young people, and probably because also they need to be at home, they can't communicate, and some other problems, of course, arise. But this anxiety situation, anxiety disease, it's really burden for the society, and like it create additional, let's say, additional monetary problem also for societies and for, to handle this kind of clients. So we expect, and actually it's already happened, increase in patients in all psychotherapeutic settings and in psychiatric departments due to the anxiety episodes. Okay, so how it's all happened? Usually our perception of the threat of some situation depend on the context. And it means that if we expect that this situation is not danger, we will probably not develop anxiety. Let's say you are in Halloween party, right? And everybody dress in very weird way. So you probably is not going to be very afraid of your friend and maybe will laugh with them. But if you are going to just walk somewhere on the street and somebody in very strange dress coming behind you, you are going to be afraid, and it is normal. So of course, context is very important. Another situation is reactivity of stress regulation system. It's also depend of the basal level of the stress systems activation. Like, for example, if you have increased level of glucocorticoids, a stress hormone in your system, so you more likely will be anxious at particular situation. So what happens generally in the brain? When we see something, or we hear something, or we perceive it from the internal world, let's say, so it's not necessary to have real problem outside. It can just come in your mind. It can be some thought, it can be some memory, it can be some feeling. But anyway, if you perceive something, in this case, just example, let's say we see something and this information processed somewhere in occipital lobe. If it's considered to be important, it's transferred to the amygdala, and amygdala, if overactivated, which is quite often a case in anxiety disorder, so it will go further to the anterior cingulate cortex, and then prefrontal cortex, and so on. So all this reaction is coming, and it's really involve many different parts of the brain. Prefrontal cortex actually change how we perceive the situation, because it's also deal with function named anticipation. So what we expect, if we expect that is going to be something bad, we already going to look at the situation that how from this point of view. What is different areas they are doing very shortly, of course. So brainstem taking care about autonomic arousal, and amygdala is activated in case of perceived threat. It triggers circuits which involved in preparation and execution of motor reactions. Anterior cingulate cortex amplifies signals from amygdala, and hypothalamus modulate anxiety states, and prefrontal cortex allows us to regulate anxiety. It can actually shut down the amygdala reactivity, and can cancel all this, for example, panic response. And prefrontal cortex involved in cognitive flexibility, in goal-directed behavior, decision-making, strategies. All of this is important and actually quite often disturbed in people with anxiety disorders. From the neurobiological point of view, anxiety believed to be related with abnormal reactivity in limbic system. And limbic system, it means amygdala, hippocampus, insula, medial prefrontal cortex, temporal lobe, precuneus, brainstem, also fear network involved. And amygdala is one of the core structure for fear network. Actually, amygdala is a very interesting structure because it's also a central hemosensor. It detects changes in CO2, and it triggers hyperventilation response to increase system pH. So this is very interesting situation. You can imagine that if we have hyperactive amygdala, and we can expect the person may be hyperventilating, and we see it in our anxiety patient quite often. This is one more example of what's happened in the brain in normal situation when we have some stress. So normally prefrontal cortex is going to adjust the level of anxiety. because it has some direct connection to the different part of the stress regulation system. And it will downregulate amygdala, can influence sympathetic outflow, so to suppress this heart palpitation, for example, and influence hypothalamic HPA axis control. If we have anxiety disorder, so usually prefrontal cortex is not so active or can't perform on the best level. In this case, we can expect that it can actually decrease or downregulate amygdala overactivation. So it can't control that much sympathetic outflow and other, can't affect other stress regulation systems. Yeah, as, I already told you that there are many different types of anxiety disorders, like general anxiety, generalized anxiety disorder, panic disorder, phobia, social anxiety, and so on. And from the neurobiological point of view, in general anxiety disorder, generally, we say that amygdala is overactivated. Anterior cingulate cortex also overactivated. Then there are some deviation in parietal cortex, in orbital frontal cortex, in the ventrolateral prefrontal cortex. In panic attack, in panic disorder, we expect, or it's written in the papers, it found that we have again overactivated amygdala and anterior cingulate cortex, but then we have hypoactivation in prefrontal cortex. We have some problem in insular cortex with decreased activation. Hypothalamus shows also increased activation in panic disorder. Thalamus shows hyperactivation, and brainstem also increased activation. In phobia, more or less the same situation can be found, but also prefrontal cortex shows increased activation. Social anxiety, quite similar, besides striatum, that is also involved in social anxiety, and ventrolateral prefrontal cortex shows reduced activation. This table just shows summary of data, of published data. And of course, most of this research done on the groups, so it's not individual clients. And there can be some misinterpretations, and maybe you can find other publications that may not tell exactly the same thing, but most of them, they shows that amygdala hyperactivated and anterior cingulate cortex also. Do you have any question until now? If everything is okay. Okay, so I will continue then. Yeah, and when we talk about quantitative EEG analysis, right? So we are today come here to understand quantitative EEG and what we can find from there. Again, general findings, because publication on anxiety, there are tons of publications, you can find whatever, but generally what most of the publication telling, it's increased beta power frequency overally or in frontal central parietal areas, quite often right hemisphere overactivation, some they telling us about decreased activation in the frontal areas. But again, this is depending of what type of anxiety this group has, and so on. One more table just about quantitative EEG. So general anxiety disorder usually shown with decreased alpha in occipital, in posterior temporal cortex. We can find frontal asymmetry. We can also find decreased connectivity or coherence within prefrontal cortex, in amygdala and posterior cingulate, precuneus and medial prefrontal cortex. In panic disorder, quite often we can find theta activity over parietal occipital areas, frontal asymmetry again, but in this case, increased connectivity in the anterior cingulate and right posterior cingulate cortex, right amygdala and bilateral precuneus. In phobia, similar with panic disorder. And social anxiety, general decrease in delta, theta, and beta frequencies, increase alpha, decreased connectivity within medial prefrontal cortex, and increased connectivity within the dorsum, within default mode network. And whereas precuneus is going to show this increased connectivity within this network. Precuneus will be as a main hub in social anxiety. Two networks more often shown to be involved in anxiety in literature. It means salience network, which involved in communication, social behavior, self-awareness, perceiving and responding to homeostatic demand, integration, sensory, emotional, and cognitive information, and many other things. And what type of structure actually are the part of the salience network is anterior cingulate cortex. We already talked about this. Insula, amygdala, hippocampus, ventral striatum, thalamus, brainstem nucleus. So all of these systems already mentioned before. Also, default mode network shown to be deviated in people with anxiety disorder, and default mode network is taking care about higher order integrative mental functions, self-consciousness, self-processing, moral reasoning, memory recall, envisioning the future, emotion regulation, resting state, sleep, and list can be longer. What type of structures? Medial prefrontal cortex, precuneus, angular gyrus, anterior cingulate cortex, and temporoparietal junction. So again, overlapping with neurobiological findings that are already presented in anxiety disorders. So functional brain diagnostic, or QEEG, allows us to look into the brain without fMRI or PET scan. It's easy, it doesn't cost so much, and everyone can learn to use it, but it's quite informative. So we can we can provide quite extensive analysis for brain waves to understand different brain states, the level of brain activation, which part of the brain do we have like normal pattern of activation and distribution of this brain activities are correct. We can measure different parameters, like for example, we can create different power spectra, and do some independent component analysis, and so on and so on. So it's really powerful technique. We also can do some coherence or interaction diagrams, Loretta source localization to understand which parts of the brain, which brain areas involved in particular pathological case. So what we can do if we use quantitative EEG analysis is also called functional brain biomarkers. We can actually use this information for a personalized approach in psychology and psychiatry. We can provide differential diagnostics and also some prognostics. So where we go with this client, psychopharmacology. We can also identify some affected brain networks, develop individual brain modulation protocols, and also we can measure effectiveness of therapy. In many cases, we can use QEEG for psychopharmacology. So it's possible to predict response to a specific medication. And now I will show you some real cases. If everything is okay, and should I answer to some questions? Hello? Okay, so then I will continue. This is the case of young woman. She was diagnosed with generalized anxiety and depression. This is power spectra map, and you can see that she has different, we make comparison with the normative database for this client, and these black lines at the under each graph represent significance. So it means that this deviation in this frequency is statistically significant. In her case, we can find downregulation in Brodmann area 8 or middle frontal gyrus, and also in parietal lobe. She has a panic disorder, she has depression, so it's not only that she has some elevated beta activity that is often found in people with anxiety disorder, but she also has elevated theta and alpha activity. Another client with similar symptoms, also general anxiety disorder and also depression. But in this case, the only deviation that we could find is increased activation in frontal areas, even though this both clients, they was diagnosed with similar disorder, and at some point they show similar symptoms, but their brain activities show different pattern. It means that if we suggest some neuromodulation protocol, we need to take into consideration specific brain pattern what we have in this particular client. Again, generalized anxiety disorder, and here we can see that it's really overactivated frontal lobe. Also, we have some deviation in posterior areas, but when we measure QEEG into conditions in eyes open and eyes closed.
Sorry, just in case people do not understand, this is the difference between normative database and their customer data. Am I right?
Yes. It's already all cases. What I show you now, it's already. This is a comparison with the normative database. It's not a raw data.
Yeah. So that's why the graphics are going up and down on the baseline. So what is up is the increase, and what is down is decrease of the activity.
It's decreased. Yes, exactly.
Yeah, just want to be sure that everyone got it. And Olga, we have the question in the chat, if you don't mind. So would you mind?
Yes, I can answer it immediately. Yes, absolutely. Menstrual fast influence anxiety level. Absolutely. I don't have specific research done in this on this topic, but it will be very interesting to look from the research point of view, because this is something that women experience quite often.
And Olga?
Okay. Yeah, Olga, I am muted.
The question
Olga,
is,
Olga Bogdanova, so you can go ahead with the voice.
It was my question. And thank you, Olga, for very interesting and perfect presentation and very beautiful. And your comparison with normative database means that you compare with some average woman, not with concrete menstrual phase. Moreover, each menstrual phase means differences in approximately 1.5 hertz in individual alpha peak frequency. So when you compare with average woman, some average phase, not concrete phase of menstrual cycle of woman, you can just see some not personal data. You can receive absolutely, you can receive a mistake. Yes?
I don't think that we do any mistakes in this point. I explain why. You know, even though, of course, we try to be as precise as possible, still we have some limitations, and we need to understand at least general trend. Like, for example, it's not only menstrual cycle, right? If your client or your patient have some medication at the moment, like antidepressant, they can increase beta waves in EEG. Yes. This also should be taken into consideration. Of course, many things can affect. Therefore, if we are doing this kind of reports, QEEG reports for our customers, we usually ask them to provide additional information, the amount of medication taken, the time, the menstrual cycle, if there are any, like, for example, this is 65 years old woman, right? So I don't think that
65 years old woman, it's okay, but
it's not anymore a problem
about talk. And
but I agree with you totally.
Normal database that with what you compared your results was constructed for average woman without pointing the menstrual phases. Did you understand it?
Yes, absolutely. And totally agree with you. Absolutely. You are totally correct and right. And that's what I also mentioned. We should work more with HBI Med, I think, to make an addition to the database, maybe to create some more specific,
absolutely.
And specific comparison. But in this case, we try to understand at least something, at least some trend, some average.
Yes, I understood.
What's going on?
I understood. And the second question is about EMG. If Alex, do you allow me to ask?
Yeah, go ahead. So you already started.
Thank
so
you.
I'm not going to interrupt.
Thank you. Thank you, Olga. At this picture that is now on the screen, in eyes open condition, you can see so-called increased beta. And did you differ? Do you know that beta and low amplitude, low, not high amplitude, low amplitude EMG artifacts, tonic muscle contraction or tension of scalp muscles, are reflected in coherence, in high coherence with EEG in beta range from 13 till 40 till 30. So your blue color on the spectrum
Mhm.
could mean that they're just psycho-emotional tension. Moreover, it's general anxiety disorder, woman, yes, woman. It doesn't matter who. But did you, are you sure that it's not EMG contaminated EEG? Did you
Yes, because
understand the question?
yeah, this is absolutely a right question and correct one. And thank you for this question. Yes, I'm very careful with EMG actually. This is decontaminated, very carefully cleaned out.
How? Is it possible with
It is
independent
possible.
component
First of all,
analysis? It's
yeah.
almost impossible.
Can
If you
I
have
can I tell a few words about EMG and stuff? Actually, this
Mhm.
is the outcome of the analysis. So of course, all the data is visually inspected, and also you see the customer usually, and so you can also evaluate the behavioral parameters, not just the EEG traces in this case. So and of course, this is the aim for diagnostics. So we don't say that this is the only possible approach to evaluate the EEG and to make the diagnosis based on just spectra. So what we are talking about the general approach, and of course all the data is visually inspected, and we know, and of course you mentioned the ICA and EMG. We don't consider that we can suppress EMG using any existing method of quantity analysis like independent or any other method, but then you do, that's why we do always the visual inspection and manual artifacting of the data, just erasing some parts from the analysis which has the real EMG artifacts and stuff. So you are totally right with your questions, and of course you're not able just to look at spectra without having any other data obtained before or during the investigation and without visual inspection of EEG. So it's not like a piece of cake that you compare your data and get the outcome you can trust. So this is the aim for diagnostic, and this is one of the tools you use. So I think, did I answer your question or just?
Yes, it's a problem, Alex. Yes.
Yeah, it's a problem. I agree with you. And every
yes, and
initial faces with problems. So that's absolutely right.
Yeah. I don't see how
right,
to solve it. Moreover.
First of all, it's quality of recording. The quality recording.
No. Is if psycho-emotional tension, it doesn't depend on quality of recording. And I think only one way could be to put a lot of electrodes and exclude EMG in the independent component. I don't know.
Yeah.
I don't know. Excuse me, fellow.
That's fine.
And I also show here only very clear cases. Trust me, I have different kind of cases. It's like the most clean cases what we have here.
Olga, it's very illustrative case. Exactly at this picture. You see, and when eyes are open, contraction is increased in comparison with eyes closed. And you see increased better.
That's why we always do both, eyes open, eyes closed.
For sure.
Yeah.
For sure. Thank you,
and
Olga.
then
You are absolutely correct, and it is not your mistake. You understand?
No, it's not even like about something that I disagree. I totally agree with you, but it's also true that most of these people, they have abnormal brain activation in eyes closed.
I'm sorry.
This is also like
okay. Let's go ahead with the presentation. I will mute.
It's not so many slides anymore. Just few I will show. It's just some few examples. So
go ahead.
for example, in this case, besides our now discussion, so some elevated beta, for example, here, right? But then in eyes closed, we have increased alpha generally and alpha theta in some case. This analysis of independent components and S Loretta was done for both conditions, and they show similar results. So we have deviation in Brodmann area 10 from the left side. So it's from here or from here. And there are some abnormal activation in the cingulate cortex and in precuneus, in parietal cortex. So this is also explain the symptoms like insomnia and parietal cortex very often coming together. In social anxiety disorder, I mentioned previously that people could have some abnormal activation in the right hemisphere, in the right frontal cortex, and this is exactly case in this patient. So decreased activation in right frontal areas and some abnormal activation in precuneus, in occipital lobe. Panic and phobia also has many phases. And again, for example, here we have both elevated alpha and elevated beta activity. Elevated beta, especially in the occipital areas, in some temporal parietal areas, and so on. And so what type of system involved? It was cingulate gyrus, limbic lobe, emotional regulation, and precuneus parietal lobe again. And actually this person also previously was diagnosed with depression, but couldn't tolerate antidepressants. And then diagnosis was changed, and they told this client that probably it's panic disorder and some phobia symptoms also presented. If we look into the coherence map, we can see these blue lines. They're telling us decreased communication within the frontal areas at certain frequencies, and also abnormal communication between frontal parietal areas. Also, panic disorder has different type of activation. So all this panic disorder and generalized anxiety disorder, and so all disorders, it's some diagnosis what was given by psychiatrists to these people, not me. So this person has hormonal disbalance, anxiety problems, sleep dysregulation, and the problem was in insula, in frontal areas of the brain. Yeah, and this is basically it. So that's just few cases I want to show you. The idea was to demonstrate that anxiety disorder, there are many. They can coexist with another type of symptoms. We should be very careful when we try to construct some protocol, and we should always put our client first or our patient first and try to understand exactly his condition. If we talk about personalized neuromodulation, whatever you are using, neurofeedback or maybe tDCS or other type of techniques to help your client, you always should keep in mind that anxiety disorders is kind of spectrum. There are many different things that can be involved. And we always go from the symptoms that is presented from this particular customer. So thank you for your attention, and I will be happy to answer to your question if there's any additional questions at the moment. Hello?
Okay, if anyone has a question, I can unmute you. So just let me know, give me a hit. Okay. Or you can just type your questions in the chat. Or Olga, if you don't mind, you can give your contact if someone wants some consultation or any other type of communication, they can contact you.
In this presentation, you can have my email. So please feel free to reach me by email. And if you need any additional contact information, you can ask from Alex. Alex, you can share it then. But I think email working quite nicely with most of my colleagues.
We got a question from Caroline. Can you read the chat, please? If you want, I can unmute you, or if you're happy with the typing, that's fine.
Okay. When we are doing S-Loretta, first we perform specific analysis based on the independent component analysis, and of course we choose the maximum. Like for example, if I see from power spectrum maps that we have elevated, let's say alpha or theta or whatever beta, then I choose this frequency, and then I go to S-Loretta and analyze it precisely to understand what's going on.
So we're using S-Loretta and Loretta to get the actual source of the activity. The location where it starts, or the maximum peak is.
Yeah, and beta, usually if we talk about in comparison with the normative database, we see abnormal beta, and like I will show you in the real case. Let's say here, yes, we have elevated beta. So beta is up, like this green wave, if we can say so.
Yeah, if you see in the center on the CZ, am I right or not? If CZ, you see the green thing, and also occipital O1 and O2. So you see the beta also in the temporal as well. So pretty much beta here.
We can say that, for example, occipital lobe is overactivated. Did I answer to this question?
Hello.
Yes,
hello.
We can hear you, so you can keep talking.
Yes, my question is, I saw that picture, for example, the Bromo area 7, and the red side means the, what's this band? Is the alpha band or maybe the beta band? It makes it red.
Can you please repeat once again your question?
Okay. So let's look at this slide. I saw the picture of Bromo area 7, and the Bromo area 7, we will see like the brand map will be the red on the maybe the under this the Bromo area. Yes. So what is this band? This band is the beta band. Because of the beta band, so it will become the red side.
Okay. Probably you mean like I just show some deviation, some Loretta, whatever Brodmann areas here, and how it's related with this picture.
Yeah, exactly.
Yes.
Right. So this is the first, let's say, part of the analysis. Not first, but this is already comparison with normative database, and this is clear deviations at certain frequencies. We have decreased amount of delta and theta, but increased amount of alpha, for example, in parietal area. Then I want to understand where this alpha come from. So what is the source? I can do this S-Loretta and try to identify the area. and this will be Brodmann area 7. Then we have some elevated activity in CZ. Actually, here is both of them. Like we have elevated alpha and elevated beta. So we can choose, but usually both of them, they come from more or less the same area. So if you try to identify the source, it's going to come from Brodmann area 24.
Yeah, so yeah, that's right. So it's just the maps of these increase alpha and increase beta. So we actually map the frequencies in Loretta, we can say, and get the actual source of this activity. It's like low resolution brain magnetic tomography. That's how Loretta is.
Why we need this brain Brodmann areas? Just to understand better the symptoms. Of course, here I didn't tell about all symptoms what we have. Normally, it means if you work with some person, it means that this person has psychological evaluation. It has some medical records, or at least we ask to share if they want. But psychological evaluation done in our center. Then we have this QEEG. We do some event-related potential. So it's really not just one parameter. We always try to use many parameters to understand this client better, to suggest the most appropriate protocol.
Okay, thank you.
Well, thank you for the question.
Thank you. Yeah.
So it looks like there's no more questions for today. So thank you everyone for attending this presentation. Thank you, Olga, for giving this presentation to us. It was really nice to see that. As I told you, it's being recorded and will be published, so you can have a look at that if you need, or share it from YouTube. If you have any questions, just feel free to email to Olga, or you can also join our group if you haven't been on Facebook. It's the Mitsari EEG user group, and you can also type your questions there. Not only Olga, but many other experts and EEG practitioners will answer them for you. So thank you once again. We will finish our webinar for now.
Thank you everyone for your attention, and I really hope that it was informative at some point. Maybe you learned something new, or maybe you can use it somehow in your practice. So please feel free. I will be happy to ask me more, and I will be happy to answer and help you if you need. Thank you very much.